and Manchester Met. I have a few other jobs. I'm clinical lead for National Clinical Audit of Psychosis, and psychosis is my usual area of work. And I'm also clinical lead for the Mental Health Clinical Research Network across GM and a few other things. So today I was going to talk to you as much about a paper about the importance of writing papers and the importance of how you choose what you write and how it can influence things. So as I say, it's as much about this paper and the findings, it's about the importance of actually people publishing. And so the one I want to talk about is a paper that was published in British Journal of Psychiatry back in 2019 with some great colleagues, and it was a psychological screening of adults and young people following the Manchester Arena incident, which many of you will remember only too well, and the tragedy of that. So, as with many things, this comes with a kind of history and a kind of sense of where things come from, and it started in terms of my very first publication that I was involved with was following the Manchester bombing of the Arndale Centre, and at the time, I was working as a CPN, and I was just starting in terms of my psychological therapy career and learning kind of how to deliver psychological therapies and CBT. And at the time when the Arena bombing happened, I was asked by Else and Adrian, a few others, whether or not we would help and support clinically people who presented for psychological treatment. I mean, we obviously all went in on the day and manned phones and did all those other things, but it was important to kind of think how we could support people post that incident in terms of the distress that they were experiencing. And the data that we had here was really helpful, not just in the fact of how we impacted on things, but if you look at the kind of flow charts and the flow through of the people, that's 102 patients attending the hospital on the day of the bombing. We made a decision not to offer those patients debriefing, but we screened them 8 weeks later. 74 patients were screened with questionnaires, 25 returned them, 12 scored above threshold, 2 were children, etc. And what you get down to is out of that number, the number of people who required some kind of intervention. And alongside lots of other data, so data from Omar and data from other trauma incidents, including this paper itself, it helped us understand how we could develop a system of care for people following the incident in Manchester at the Arena. Now, at the time, I was working as the adult mental health clinical lead for GM at the Strategic Clinical Network, and we kind of wanted to ensure that we kind of had a mental health response that was really up to the mark. We didn't want to just let this go. I remember going to a meeting. It was somewhere in Manchester. I can't really exactly remember the venue, but I do remember there being about 200 people at the meeting, and it was about 4 to 6 weeks after the Arena incident had happened, and everybody was pretty much saying, wow, what a fantastic job we've done. That's it, off we go. Move on to back to the day jobs, and hopefully, it'll be some time before the next time we're required to have a mass trauma incident that we respond to. And this was predominantly, if you think about orthopedic surgeons, it was about trauma kind of workers, it was about people from blood banks, etc., who'd really kind of done a great deal of work, but it seemed that was the point in time that they'd done their job. We were highly aware from a mental health perspective that this was pretty much the time that we needed to pick up and start to deliver some kind of response. We very quickly kind of wanted to ensure that what we did was we reached out to as many people as possible in order to try and offer some kind of psychological input post-Arena incident. obviously, because it was at the arena, it was a ticketed event. And we thought that that would provide some level of ability to reach out to people, because, you know, if you'd signed up for a ticket to attend a concert, somehow there'll be some contact details. And we knew that it wouldn't be 100% accurate by any means, because, you know, people buy tickets for a number of people, or ticket touts will buy them and sell them on, so we knew it wasn't foolproof. But we thought it was a good starting place, that we could kind of reach out to people that were there on the evening, alongside a few other strategies. But we also knew that it wasn't just a Manchester incident, it was pretty much a north of England incident. So, you know, we all know the arena, it attracts, you know, people who come from across the Pennines, from Liverpool and quite far north. And what we wanted to make sure was that whoever attended on that night got a similar kind of response. We wanted to ensure we delivered a good response to people. So I worked with a great colleague of mine, Pratibha Chitsabeesan, and another great colleague, Sarah Barnes, and we did a whole load of work to kind of think about what a kind of mental health response might look like. And we worked with the military vet services, etc., and came up with this hub approach that we would kind of ensure we reached out to people as in an assertive outreach approach, to ensure that we somehow could kind of follow people up, and that led to the establishment of the Resilience Hub. We wanted to prevent long-term kind of, you know, complex trauma as much as practically possible, and so that meant a long-term follow-up as much as we could. And Pratibha and myself have been involved in leading the evaluation of that initiative, because we wanted to make sure it was the right thing to do. We've done a number of things. We looked at a process evaluation, a participant evaluation, and quantitative data from screening measures. And it's the quant data I'm really going to focus on. Basically, the kind of the process evaluation was pretty much saying that on the whole, it was pretty much agreed that what we did was right. Because it was done at pace, we could have probably done things a bit better, which we absolutely recognise. But when things like that happen, you just have to deliver at an inordinate pace, which sometimes means that you can't do everything that you'd quite like to do in terms of collaborating with other people. But on the whole, we did the right kind of thing. We've literally just published in terms of people's experiences of distress and psychosocial care following a terrorist attack, and that's available online now if people are interested. But what I wanted to focus on was the data-driven paper, because this was a fascinating piece and something we're pretty close to finalising a long-term follow-up. But this gives a real sense of trajectory, and I wanted to highlight that really. So the background to it was that we know that terrorist attacks have increased globally. That it's not just, you know, system, and it's just as important at the present time as we can see by the trauma that's been inflicted on you know, people living in Ukraine, and the devastation that's there. So how to respond to mass trauma events, not just about terrorist attacks, I think is such an important issue. So our aim was to examine the severity of the symptoms and the impact of the programme that we had on those symptoms, and to see whether or not we delivered what we hoped to do. So the method was, we had the hub, which was a clinically kind of delivered service that we advocated for, and we want to see whether or not this is the right way forward that we can advocate for in long term. It's important to know that when we first set out to deliver this clinical intervention through the hub, there was some pushback centrally, and people thought it wasn't the right thing to do. But we kind of went on regardless, and actually got quite a bit of support from Greater Manchester. GM itself was a very supportive environment to be in at that time, but centrally they were kind of against this. But we progressed kind of regardless, and thought this was the right clinical offer. So we wanted to check that whether or not it was. So the hub was there. It delivered outreach and screening and telephone triage, facilitated access to evidence-based kind of treatments, and we screened people for trauma, depression, anxiety and functioning. And in this paper, we presented our 3, 6 and 9 month post-incident scores to see how we were doing. And that was across both adults and children. We followed people up, and we've pretty much just about cleaned and analysed our 3-year data. So we followed this group up for 3 years, and we're not far off publishing in relation to that. But in terms of this, what we found was that there were significant differences in baseline scores across screening, across the different groups, and really what it was telling us was the crux of this was that almost unsurprisingly, people who registered early with us were less symptomatic, and they demonstrated greater improvement across a range of psychological measures, which seemed to fit with our hypothesis that if we could get to people earlier, if we could offer a preventative approach, it would offer some way of mitigating some of the difficulties associated with long-term complex trauma, which emerges over time. And it was also an important thing that through the screening process, through kind of contacting people at these various different time points, we were also able to offer kind of important messages to reach out and say, look, just to let you know, we've not forgotten about you here, which is often the case when people go through these things. They kind of describe feeling the love during the kind of immediacy and aftermath of large-scale trauma events, but very quickly can feel forgotten because something else has happened. Partygate's happened, Brexit's happened, something else has happened, which mean that they're feeling left behind and not kind of cared for in many ways. So the opportunity to rescreen people was an opportunity to remind people that we're still very much thinking of them, and if they're having difficulties, then by all means, let's get in touch to see if we can offer you some kind of help and support. So that was pretty much the crux of the paper, and it was about examining people's scores at 3, 6 and 9 months, to seeing how they differed between those 3, 6 and 9 month cohorts and whether or not people improved. It was a very early kind of cut of the data, but it was an early cut of the data which allowed us to think, well, we seem to be on the right track, let's continue what we're doing. Now, going back to my original kind of suggestion of why I was interested in this paper and presenting this paper, and as to why to publish, what we know is that in terms of the recent trauma that we've had with the pandemic, we saw that NHS England set up multiple resilience hubs around the system, pretty much based on the hub that we developed at Pennine to deliver across GM. And they pretty much kind of took the methodology that we had and they replicated it. And they're able to do that, not just based on the kind of narrative that we have, but some of the data that we have here. So it was to really encourage lots of nursing colleagues that actually publication isn't about just, being some clever academic. It's not just about, it's a great way to get on and kind of have your career kind of measured and ref kind of, impact. This is about real world impact in terms of people. And I suppose that's why I was keen to present this paper, because it does provide a clear trajectory for what we did, how we evaluated, and how that evaluation then fed into a national strategy for how people wanted to support health and social care staff who were traumatized by treating people with the difficulties, all the issues we saw around the pandemic, and how that was moved into clinical services in a very quick time frame. People often talk about the fact that it can take 17 years from a kind of research idea to get into practice. Clearly, this was stuff that we did not that long ago and is now being kind of delivered regularly right across the system. So I think that's pretty much what I wanted to say, and give chance for any questions.
Thanks, Paul. That was brilliant.
It's great.
I've got questions. I don't know, Karina and Mark, do you want to go first if you have questions?
Yeah, that was great, Paul. I'm sort of interested in what the hub actually does now. So are people referred to the hub?
So GM Hub, which has been around for some time, is probably one of the because it was the first one, has been established, and it's actually currently reaching out to people in health and social care who have got relatives in Ukraine, and the distress that they may be experiencing. So I always envisaged the hub as being a flexible way of supporting large-scale trauma events. If you remember the case for Reynard Sinaga, which was the gentleman in Manchester who sexually assaulted lots of young men in Manchester, with following giving them access to various drugs. The hub was part of the response to that. So the hub's been fairly light on its feet in being able to know how to work with large-scale trauma events and hold that, and being able to offer into the system a way of managing that. And that's always kind of what I envisaged. It was, its work with the arena case was always going to come to an end, but there is always going to be another large-scale trauma. We live close to the airport. It could be something like that. We know that climate change is a big factor. It could well be due to that. There's never going to be another arena incident, but there will always be another large-scale trauma that you need to have a bit of history in how to manage, because we learned such a lot, Karina, about how to manage a large-scale trauma. And it was fascinating when we started, Pratibha and myself, we looked at the EPRR guidance, and there was nothing in there about mental health. About 6 months before the Ariana Grande concert happened, there was an exercise that was held in the Trafford Centre, and they did all of their exercise. A bomb went off in Trafford Centre according to this exercise, and they dealt with it. And orthopedic surgeons came along, blood transfusion. There was nothing in that exercise related to mental health. We've now absolutely nailed it in that they've got a mental health response in part of the EPRR document, and it talks about that. And I think that's been some of the legacy. And what we've left now is a legacy of a resilience hub that knows how to respond to large-scale trauma in different kind of ways, because it will be different kind of ways.
Oh, that's brilliant. Thank you.
You're very well.
Can I just follow up on that, Paul, in terms of, I was just thinking about sort of what people's pathway might be after contacting the hub. So is the hub less a way of delivering interventions and more a way of sort of helping people be directed to appropriate sources of support, or helping people navigate mental health care pathways? How does it sort of practically work?
So it's a bit of both, really, Rob. I mean, so if you imagine in the initial incident where you had somebody who may have come from Newcastle, who attended the Ariana Grande concert, it wasn't, and this was before the pandemic, and as an ability to deliver therapy over Teams or whichever medium they used. It probably wasn't appropriate for the hub to offer therapy directly to that individual. They facilitated therapy in Newcastle for them if they were struggling to get it, or if they were unsure about what to do, but their scores really indicated they were struggling. So that was very much part and parcel of it. We knew we'd never get to see everybody in person, so we needed to have some way of facilitating kind of treatments. But there were other treatments that weren't just readily available. So if you think about the concert, there were people who went with families. So it was a whole family unit was there. And there wasn't really a system of care that was there to deal with a family unit in terms of their trauma. So the hub actually developed a lot of specialist expertise in saying, how can we go into that family who've been exposed to a specific trauma event and support you with regards to that? So there's a lot of learning went on there. And that was quite a specialist intervention that they kind of developed. So it was a real mixture of the two types of interventions, where lots of it was, about signposting, about making sure people got to the right kind of treatment, to the point that we actually got gifted, and I think it was from one of the large travel companies. I think it was from Thompson's. They actually wanted to do something and actually made a gift of a substantial amount of money, and we actually utilised that money to pay for some private healthcare if it wasn't available in someone's locality. Because actually, we know for CAMS there can be long waiting lists and lack of service provision. So we ended up using that to say, well, we've got some money here, we can pay for some private healthcare for you, if that would be of assistance. So it was a whole mixture of interventions, pretty much designed around how we could minimise distress for that population that presented.
Brilliant. I've got another question, but I don't know if you had a question or a comment.
Just make a comment, I guess. Just you mentioned about the people feeling the love sort of post incident, and it was amazing, wasn't it? Sort of following that event, the picture you're shown of St Anne's Square with all the flowers laid out, and things like people getting tattoos done. The bee suddenly, this sort of symbol we had of Manchester suddenly became known to everybody, and people were, getting tattoos and stuff like that. It was quite remarkable and amazing that it's like almost 5 years ago now. And like the current news, everything that's going on, you think of this one horrendous blast, and the injuries and the deaths that resulted, and then you think of just the scale of that's going on sort of before our eyes, sort of in Europe at the minute. It's amazing. But I suppose one question in relation to the work that you did, Paul, was the difference between the 3 and 6 month. The people that presented at 6 months, how they had higher scores, and I just wondered what the sort of what the explanation of that might be, really, whether it was about people being seen earlier, sort of accessing treatment and maybe managing those symptoms sort of early on, which was better, or whether people with more severe symptoms maybe took a bit longer to sort of present at sort of 6 months. I don't know. What was your view about that?
So there's, people recovering so I think in the paper we talk about 4 different kind of recovery kind of
it's interesting.
And so people, thank Christ we're all different. It'd be a pretty tedious world if we're all the same. And people respond very differently to these kinds of events, and kind of get better or worse in different kinds of ways. And I think some way what we saw is almost a modelling of that some people would kind of respond in certain kind of ways. But we always had a kind of belief that if we could reach out to people sooner, the sooner we could reach out and say we've got this system of care in any preventative kind of way, the sooner you can get help in a preventative kind of way, the better. But we also knew that there was a group of people who probably would, and long-term complex trauma typically emerges, and sadly amongst lots of health care professionals, that what happens is people try and manage, and you try and manage yourself, and then you kind of know you're struggling, so maybe you kind of end up thinking, oh, I'm going to have another glass of wine tonight because I'm really bloody struggling. And before you know it, you're having more than one glass of wine, and you're having several glasses of wine on several evenings, and then that escalates, and you continue to self-medicate and somehow trying to get through, and your life starts to fall apart. And actually, that then gets a bit confused about whether this was part of the original trauma, or whether it's just you as or whatever's going on. And so that real complex trauma, that was one of the things that we were really trying to avoid. Which it was way off 6 months. It probably 2, 3, 4, 5 years down the line. We ideally would have loved to evaluate up to 5 years, but we just didn't get any kind of traction with trying to do that. So I think even 6 months is hard to say, well, this is long-term trauma setting in. This is just a kind of a factor of the data of the people that were coming along to us. We also think some of it was to do with that. Probably what was happening was that we know we saw, you got to go, Karina.
I've got another Zoom. Great stuff. I'd love to talk to you about it more.
Yeah. Catch you soon, Karina.
Yeah, will do. Bye.
Thank you. See you,
Bye.
Karina. Bye-bye. Bye.
Yeah, the other thing is that probably what we also saw was that we know lots of families that were there. They were keen to make sure that their kids got help first before the parents got help. You know, a bit like that thing in an airplane where the oxygen masks come down. You kind of make sure your kid gets the oxygen mask first, and then you put yours on. So some of it may also have been that you know, adults were actually fairly keen to ensure that, you know, other parts of their family system got help first before they then registered and start to get help. So there's a whole range of things, and I think it's hard to definitively say, to be honest, Mark, what it was. I think all we could say really is that was what we found, without any real certainty behind why that was the case.
Right. That was the question I was going to ask, actually, Paul. So you've that's brilliant. So is that a good point for us to finish? Thanks loads for doing that, Paul. I really appreciate it. It's a fascinating paper, and you know, amazing reflection of all the work you did after the Manchester Arena bombing.